Hello everyone, my name is Mina Hanna, and today my presentation is Not Every Hallucination is Schizophrenia, Untangling Psychosis, Mood, Substances, and Medication Withdrawal Across Detox to Residential Transitions. This case study will explore the complexities of diagnosing, managing a patient with tangled history of substance use and psychiatric symptoms. To begin, let's review the patient profile and history. Our patient is a 58-year-old male who was transferred to our residential facility from detox with a SIWA of 1. His history reveals severe polysubstance use, including alcohol, cocaine, opioids, and benzodiazepines. Psychiatrically, he has a significant burden of illness, with approximately 15 past hospitalizations for suicidal ideation and chronic mood symptoms that have reportedly not seen remissions for longer than 2 months. During his transition from detox, the patient experienced marked anxiety, irritability, and insomnia. However, we observed that these symptoms improved once olanzapine was reintroduced and tapered. This provided a critical clinical insight. His acute distress was likely iatrogenic, specifically an antipsychotic withdrawal syndrome, rather than purely substance withdrawal or worsening anxiety. Additionally, we assessed him for movement disorders and we found an Ames score of 15, indicating tardive dyskinesia, characterized by orofacial movements like smacking and grimacing. Notably, the patient was entirely unaware of them. To navigate the diagnosis, we identified a diagnostic anchor, a reported 10-year period of sobriety while the patient was incarcerated. The key finding from this period was that he experienced full major depressive episodes accompanied by persistent visual hallucinations of shadow figures. The crucial distinction here is that he had no periods of psychosis lasting 2 weeks or longer in the absence of prominent mood symptoms, which is vital detail for our differential diagnosis. I selected this case because it impacts advanced practice in 4 ways. First, it helps prevent unsafe prescribing, such as high doses of antipsychotics, and models effective interprofessional collaboration during handoffs. Second, it highlights the diagnostic complexity of distinguishing substance-induced disorders from primary disorders. Third, it addresses iatrogenic harm, specifically regarding side effects like tardive dyskinesia and withdrawal syndromes. Finally, it illustrates the risk of diagnostic overshadowing, where we risk mislabeling mood congruent psychosis as schizophrenia. The core challenge here is determining the primary driver of patient symptoms among four potential pathways. Is it primarily substance induced, mood disorder driven, schizophrenia spectrum, or iatrogenic? The consequence of error is significant. A premature label alters his long-term maintenance strategy. Therefore, our approach is a timeline-driven diagnosis that maps symptoms strictly against his windows of substance use and sobriety. The psychosis spectrum. Looking at the psychosis spectrum, we first consider schizophrenia. While the patient fits the duration criteria of psychosis lasting longer than 6 months, we can't rule it out because his psychosis never occurred outside of mood episodes. Next, we look at schizoaffective disorder. This requires a major mood episode plus at least 2 weeks of psychosis without mood symptoms. Since the patient denies his 2 week window ever occurred, we can rule out schizoaffective disorder based on the DSM 5 criteria. On to our primary working diagnosis. we arrive at major depressive disorder with psychotic features. The criteria of this diagnosis require that psychosis occurs exclusively during mood episodes, which fits the patient's history perfectly. We also consider persistent depressive disorder given his history of chronic depression lasting longer than 2 years. Sensitizing this, our diagnosis is persistent depressive disorder with intermittent major depressive episodes with psychotic features, which is clinically coherent with his treatment history involving Seroquel and Zyprexa. We also needed to evaluate for bipolar disorder. The patient did report a past manic episode that required hospitalization, which would typically suggest bipolar 1. However, the caveat is that this occurred only during periods of heavy cocaine and alcohol use. Crucially, he experienced no mania or hypomania during his 10-year sober period. Therefore, the most accurate provisional label is substance or medication-induced bipolar disorder, and our action plan involves longitudinal monitoring during sustained abstinence. Regarding the differential diagnosis for anxiety, the patient presented with chronic worry and restlessness, matching JAD criteria. However, there were significant confounds to consider, including alcohol withdrawal, the dysphoria associated with cocaine crash, and akathisia. The vital clue was that his anxiety improved significantly when olanzapine was restarted. This led us to conclude that his anxiety was likely a mix of underlying pathology and rebound physiology. In terms of management, we must strictly avoid benzodiazepines and utilize SSRIs or buspirone once stable. Turning to the iatrogenic complications, we identified two major issues. First is tardive dyskinesia, caused by long-term dopamine receptor blockade and hypersensitivity. It is important to note that the risk worsens with dose increases or rapid reductions. Second, we observed antipsychotic discontinuation syndrome driven by cholinergic rebound. The symptoms, such as insomnia and agitation, can be mistaken for relapse, but in Michael's case, this was a physiological withdrawal syndrome. Pharmacological interventions, we recommended initiation of naltrexone for alcohol use disorder to reduce relapse risk. For cocaine use disorder, we avoided benzodiazepines and noted that no FDA-approved medication exists. To address his psychotic depression and TD, we restarted olanzapine with a gradual taper of 10 to 20% every 1 to 2 weeks to mitigate rebound. We also evaluated the use of VMAT2 inhibitors if antipsychotics remain necessary. For non-pharmacological strategies, we implemented contingency management, which uses voucher-based reinforcement for cocaine abstinence, as it is the only intervention with strong evidence for stimulant use disorder. We also utilized integrated CBT to target both depressive cognitions and substance use triggers simultaneously. Reviewing Michael's case, I realized that this suffering he has encountered wasn't just because of his biology, it was because of a failure in our system. I use the Swiss cheese model of accident causation to analyze what went wrong. The first hole of the cheese was a medication reconciliation failure. When he moved from detox to residential, his olanzapine wasn't just fell through the cracks. The outcome was that Michael spent 3 days in preventable agony. suffering from cholinergic rebound that mimicked relapse. This is a massive safety issue because patients in that state often leap against medical advice and relapse immediately. The second issue was diagnostic overshadowing. The workflow in the facility biased the team to label any agitation as addiction behavior. Because of system level bias, we missed the fact that he was actually having a medication reaction. To fix this, I'm proposing a quality improvement strategy grounded in the Joint Commission's National Patient Safety Goal regarding handoffs. I drafted a psych transition handoff tool using SPAR framework. It adds a specific section for psychotropic taper status and baseline AIMS score. If we had used this tool, the receiving nurse would have looked for olanzapine taper plan immediately, and micro-rebound symptoms would have been caught before they spiraled. This experience taught me that patient safety isn't just about being careful, it is about designing workflows that don't let the cracks open up in the first place. In my clinical rotation, I learned that managing complex cases like Michael's requires us to step up and break down the silos between detox, pharmacy, and therapy. My preceptor challenged me to use team huddle approach rather than just relying on the chart. For example, regarding nursing communication, I initially noticed the detox staff documenting drug-seeking behavior. Coming from RN background, I understood their frustration. However, in my new role as a student provider, I saw the need to intervene. With my preceptor's backing, I called the nursing station to reframe the situation. I explained that what looked like seeking was actually physiological rebound from the missed olanzapine dose. It was a powerful moment for me to see how educating the team changed the culture of care from punitive to compassionate. I also collaborated with a pharmacist, something I didn't do as much as a floor nurse. We worked on the taper schedule together. But the biggest lesson was shared decision making. I sat down with Michael, just two human beings, and we looked at the AIM score sheet together. I realized that as a future NP, I'm not just dictating orders, I'm partnering with patients to manage risk. That conversation helped rebuild his trust in a system that he felt failed him. This case was a major wake-up call for me regarding my own biases. I realized I was susceptible to diagnostic anchoring. When Michael first arrived, my instinct, perhaps as my RN instinct, was to categorize this agitation as typical addiction behavior. I had to use metacognition to stop and ask myself, if I took the cocaine history away, how would I treat this agitation? This was a pivotal moment in my growth from bedside nurse to a provider. I moved from just managing a difficult patient to diagnosing an iatrogenic withdrawal. I also felt the heavy weight of the prescription had for the first time. The system failed to reconcile his meds, but I realized as the NP, the buck stops with me. I faced a tough ethical dilemma. Do I prescribe the causes toward dyskinesia to prevent psychosis? This experience really defined my transition into the APRN role. As a nurse, I was excellent at observing symptoms. The patient is anxious, but as an NP student, I'm learning to sensitize the timeline, the biology, the history, to find the root cause. It taught me that leadership sometimes means hunting down old records and having the confidence to challenge a diagnosis that has been in the chart for 20 years. As we all prepare to graduate and enter practice, I want to open up a discussion about two things that kept me up at night regarding this case. First, regarding the safety versus side effect dilemma. We are taught to do no harm, but if you have a patient like Michael, whose face is grimacing from TD, yet he becomes suicidal without antipsychotics, how we navigate that? As future providers, how do we document that lesser of two evils decision to protect our license and our patients? I would love to hear your thoughts on how you plan to handle that ethical gray area. Second, I want to talk about clinical inertia. We've all seen charts with schizophrenia listed from years ago. I found it intimidating to challenge that label as a student. When we get out there, what barriers do you think we will face in delabeling patients? How do we convince a skeptical team to accept a new diagnosis of psychotic depression when they are used to treating schizophrenia? Does anyone have strategies for having those difficult conversations with colleagues? These are the major references that were utilized for this presentation. Please let me know your thoughts about the addressed questions. Waiting to hear back from you. Thank you.